Okay, guys, let's talk about bunionectomies. So hallux valgus leading to bunionectomies, which I would say there is a good number of these in China. I don't know how often you see them for rehab, but I know that the surgery is getting done. It's get done in the West a lot. So this is essentially what hallux valgus is. So you can see it's that malalignment of the big toe. And we're going to talk about why it happens and then talk about the rehab for it. But you've probably seen this. Probably some of your moms have this. If you were to look at their feet barefoot, then you would see this kind of angle. I'm actually sort of starting to get it, so I'm trying really hard to not get it. But it's a relatively common problem. And so it's literally what happens is that first metatarsal goes into this bad angle. We're going to call it a valgus angle because that's what they call it. And so then you end up with that sesamoid bone not being lined up correctly. So you can see how, when we talk about sesamoid bones, which we really haven't done with these classes, but sesamoid bones are kind of there to help allow the tendons to move well and to not have rubbing against the, in this case, the metatarsal bone. And so you can see how if the metatarsal is shifted like that, then the sesamoid bone isn't doing its job very well. And then you have that other angle in the phalange that's also not correct. So here's just another picture. This is sort of how we measure it, and we'll talk about that. We don't have to do the measurements. The doctor will do a measurement, obviously, before they go in and do surgery to try to straighten it back up. But this is sort of what tends to happen is that sort of abduction of the metatarsal, and then that sort of adduction of the phalange or the the phalange. So if it's when you're measuring it, again, you're measuring both the hallux valgus angle, but also then the intermetatarsal angle. So the angle between the first and the second toe, basically. So this is, again, characterized by this deviation, and nobody really knows why it happens, but I think we can all say that it has something to do with footwear. So especially for women who like to wear certain types of shoes, like in the picture, and they wear them regularly, they're putting different kinds of pressure on their forefoot, and so that's going to possibly lead to these changes in angles. There's also likely a genetic component to why this happens, so at least 60% of people that have this tend to, and I'm going to use the word women because it's definitely more women than men, but I have seen it in men. But it's 60% of them have some sort of family history of this problem. So what are the things that cause it, or what things maybe cause it, is high heels. So putting the foot in a position where they're putting more pressure through their toes all day long, and then a narrow toe box. So the width of shoes I've found in China to be very challenging. You guys have very narrow shoes. So if you're somebody like me I have like a pretty average foot for a Western person, but I would say that it's maybe a little bit more wide of a foot compared to people in China. But again, if you're finding that when you put your shoes on, that you're kind of straining through the toe box, so at that MCP joint specifically, then you may consider that the shoes are too narrow, and that could lead to problems with hallux valgus. Also, biomechanics, what we do find is that if they're not able to do dorsiflexion, so again, if you're wearing something with a heel, then your foot is in a little bit of plantar flexion, or in the case of a high heel, a lot of plantar flexion for periods of time, and so you don't have good dorsiflexion, and your pressure is through the foot, and so that can be a problem. Also, that positioning, when you think about mechanics of putting the foot into external rotation or abducted gait. So we've talked about the too many toes sign a couple of times. We talked about it when we talked about the tibialis posterior repair surgery. and that idea of the too many toe sign. So when you look at a patient from the back, you can see their little toes, like their third, fourth, and fifth digits kind of out to the side. And that means that the foot is in external rotation and abduction. There's lots of reasons why that can happen. One of them that we talked about was, remember, that tibialis posterior could be weak, or you're not controlling it very well. Another reason could be because of decreased dorsiflexion. So with decreased dorsiflexion, we're not able to get that full straight-on push-off during weight bearing and then terminal stance. And so that could be part of what's happening here. And so then that position doesn't set up the big toe. If our foot's in that external rotation position, it doesn't set up the big toe to be able to push off very well. And so then we can end up with this malalignment. And if you remember when we talked about tibialis posterior tendon repairs, we also talked about the possibility that they have too much pronation, so they have that flat foot, they go into too much pronation, they don't ever resupinate, and so then again, you're causing a lot of pressure that's incorrect pressure on that first ray, on that first toe, which could lead to this problem. So remember that when we're walking, just like I said during toe off, during that last bit of our weight, the stance phase, 40% of our body weight goes through the first toe. And so if we're not pushing, if we're not using that power and doing that correctly, then we can end up with problems. And then if we end up with this problem, with this hallux valgus, then we're going to have problems with walking. So it's this vicious cycle. And so again, this is what happens. The medial collateral ligament. So again, if you looked back on that alignment, that picture, the medial collateral ligament is going to then stop stabilizing the toe very well, especially at the first MTP. And so basically we end up with that bad mechanical angle, which can lead to hypertrophy of the flexor muscles of the toe, especially the big toe. So again, this kind of shows you that picture as we progress with hallux valgus, we get that foot turning out too much. So in this case, that external rotated foot, and then we end up with this alignment where the foot becomes, goes into valgus, which you can kind of see here. So then you can see how if their angle looks like this and we're trying to push off the big toe, we're going to have a much harder time. So we end up kind of pushing off the MTP rather than the phalanges, rather than where we're supposed to push off. And then we end up causing more and more of this malalignment. So the forces, again, are not being applied correctly through that first toe. So what's interesting is that people who don't wear shoes, I don't know how many people there are out there these days who don't wear shoes, but I would say the people who live in kind of tropical areas, so, kind of Southeast Asia. Think of people, I know I've been to the Philippines many times and to Thailand, and they wear like just the really like almost non-existent shoes, where, they've just got like the really basic like sandals almost. The people who are using their feet all day long and their feet are flat and they're close to the earth, they tend to not have this problem. So populations that are essentially barefoot, but maybe not completely barefoot, are not having this issue. So it's the possibility is much higher in those of us who are wearing shoes, and again, wearing maybe the wrong shoes. So 30 to 50% of people as they get older probably have some degree of hallux valgus. Like I said, I definitely do. I'm starting to see it with both of my feet. And so I think this is a problem that those of us who, are not wearing the right shoes and are not using our feet very well, it can be a problem. And for women, it's 9 times worse. So again, much more common in women. We like to wear our pretty shoes. And I mean, I've worked with patients, and I'm sure some of you have too. The woman will say, oh yeah, when I get home, I can't walk around my home with bare feet anymore because it feels so weird. I have to wear like some sort of heel all the time. Those are the people that are very likely to have issues with hallux valgus. So for diagnosis, it's very obvious with observation. You can also do the measurements, which we'll talk about a little bit in just a second, a little bit more in a second. The symptoms, you're going to see that there's usually a callus that's formed, so that thickening of the skin that's formed at the big toe. There could also be redness and irritation, not necessarily always. I don't know that I necessarily will notice a lot of pain, but they usually will say maybe they have a little bit of discomfort or pain, and it's aggravated by wearing shoes. So when they kind of push off and they're in certain kinds of shoes, that it gets worse. They also may show swelling in the bursa along that first toe. And then that's the idea that the big toe is kind of facing the other toes. So sometimes it gets so bad that the big toe will cross over the second toe. So you can see in this case that both feet in this picture have hallux valgus, but the right foot is definitely worse. And you can see that if you let that keep going, if they keep doing things wrong, that first toe could definitely cross under the second toe. And so these are pretty obvious to see. They do a radiograph, so some sort of x-ray. Then you'll see that there's these different angles that they're testing. So the HAV you'll see is increased, as well as the IMA. So you'll see that picture there on the bottom of what angles those are, what those kind of stand for. And then again, that sesamoid bone. So you can see in the x-ray that the little sesamoid bone, that little bone, you can see it just kind of to the inside of the first MTP. And then in the drawing, in the cartoon, it's very separate from the MTP. So, it should be underneath those two bones. You shouldn't be able to see it in an x-ray or in the drawing. So deformity is considered severe when the hallux valgus angle, so that's the HAV, is more than 40 degrees, and the intertarsal angle, which is the IMA, is more than 16 degrees. Okay, so 40 degrees of that one that's kind of the one that's on top, let's say that's the HAV, and then 16 degrees of the one that's on the bottom, the IMA. So they do sometimes give severity by stages, so we can get up to 3 stages. So in the first stage, the HVA or the HAV, that should say HAV. Sorry, guys. HAV, I guess HAV or HVA, it's the same thing. Hallux valgus angle or hallux angle of the valgus, whatever, doesn't matter, is less than 25 degrees, and the IMA is less than 12 degrees. By stage 2, where it's greater than 25 degrees, the IMA is less than 16 degrees, and then when it's severe, it's greater than 40. And so this is kind of usually where they'll say, we need to do surgery. So differential diagnosis, it is important that they are able to say, okay, this is definitely the problem. But hallux rigidus is where there is osteophytes. So they would choose to do a different surgery if there's osteophytes. So again, that's that bony growth that could happen that would cause decreased mobility. So that would lead to probably a different kinds of surgery. And then hallux arthrosis, which is where they've lost joint space. So this is going to be more like an arthritis, right? Where we lose the cartilage, and so we lose joint space. And then the other thing that we see a lot with feet is gout. So, they may have significant pain, but a surgeon is probably not going to go in and do a surgery while a patient is having a gout flare up. Because there seems to be a lot of gout in China. You guys, the uric acid levels, for some reason, we stereotype it as like the older man who drinks too much. But it happens to a lot of people. I've seen a lot of gout in China. And so if they have gout, usually if it's also gout with hallux valgus, they'll probably wait till the gout is under control, because it's going to be just a really awful outcome if they try to do surgery with gout. So I would say The vast majority of patients who have the stage 1 or stage 2 don't usually need a lot of treatment. What we tend to find in conservative treatment is that patients have other issues, and then when we look at their feet, we see hallux valgus. So hallux valgus is not the primary diagnosis. They usually will have anterior knee pain, maybe hip bursitis, something like that. And so they're coming to us with these problems, and then we will obviously hopefully will do a good, observation of weight bearing and gait and other things and say, oh, wow, not only do you have really bad genu valgus, so really bad knee valgus, or you have a really bad Q angle because your hip isn't very good, but you also have hallux valgus, and so your foot doesn't look good. So we will treat all of it together, which we're going to talk about as we talk about rehab for this group anyways. We will treat all of it together rather than just trying to treat the hallux valgus. If they are being sent to you for hallux valgus, it's really about symptom management, and you'll see we definitely can give them some sort of padding or brace to help realign the foot and the toes. There are some pretty good braces out there to help realign the toes. We also will be doing a large amount of patient education, and this is true post-operatively as well, to talk about making sure that their footwear has that wider toe box, that they're not wearing high heels, that if they need to wear a heel, that it's a low heel, that they're wearing soft shoes, that they're not wearing if they like high tops, that they're not wearing like really rigid high tops, basketball shoes, whatever. And so there's a lot of give in the shoe. And then we're basically allowing for pain relief, and then you can definitely do some manual therapy. The manual therapy, again, I'm hoping we have some time to do a lab for this one, because basically you're helping them do dorsiflexion and plantar flexion, flexion and extension of the first toe with the alignment better. So you're using the brace that we talked about, the splint or a spacer, something, and getting the foot in better alignment, and then having them do the movement, the correct movement. They will probably need to do, some first toe mobilization. And so again, you're doing that mobilization in the right position. So kind of mobilization with movement and making sure the alignment is good. That can be part of treatment. We already said changing in shoes, but also orthotics. So making sure that they have good arch support if they're a significant overpronator, right? So they've got that flat foot, then you want to give them good arch support, but then exercises that really focus on promoting arch support. So those exercises, fibularis longus and posterior tibialis. So we talked about those when we talked about the posterior tibialis muscle, tibialis posterior muscle. We talked about importance of certain exercises like playing with the towel and really teaching them how to turn on their midfoot to keep the arch when they're weight bearing, when they're doing squatting, those kinds of things. Fibularis longus, again, if you remember your anatomy, fibularis longus is going to attach to the base of the first toe. So it's really, really important that that fibularis longus is lined up really well, that it's actually being turned on when they're doing push-off. So kind of looking at a single leg heel raise and seeing if they're actually using their big toe for a single leg heel raise, cueing them how to use their big toe for a single leg heel raise, so that they can actually do that correctly. And again, if the hallux valgus is really bad, it's going to be almost impossible for them. But if it's small, like me right now, my ankle's not that bad, I can practice single leg heel raises, and it will be helpful in decreasing the possibility of it getting worse. So don't forget to look up the chain, look at the knee, look at the hip. These problems are probably happening because of malalignment of the whole entire lower extremity. So make sure you're checking that. And this is going to be the same thing post-operative, right? We're not just going to fix a bone and then be like, okay, go off and do those bad movement patterns again. And then also consider using a night splint, some sort of spacer. These are just different options. These can be worn during the day as well. They're better like dynamic splints that can be used with walking. This one's probably not the best, but you can certainly use it, and especially at night. So why do we do surgery? If it's a really bad angle, the patient can't find comfortable shoes, so they're having a lot of pain. They can't, play sports, or, if they're a runner, they just can't run anymore. Those would be reasons to do it. I honestly would never, ever suggest this surgery, ever, because it's extremely painful. So, again, for me, I'm going to try very hard to not have any pain. I've never had pain with it. So I'm going to try everything I can to not let it get worse. And if it gets worse, I don't care. I'm just going to find different shoes. And I think you'll notice that a lot of people in China, that's true. Your older people, and this is true in America, they just find shoes that work for them. And no, they don't do surgery. However, I do have a couple of friends who also have this hallux valgus and have had surgery because they didn't like the way their feet looked. So if you don't like the way your foot looks, I'm sure you can find somebody out there to do the surgery for you. The technique, I'll show you a couple pictures of some different techniques. There are lots and lots of different techniques, lots of different ways to do this. It's mostly based on the different deformities, but the most common ones are these three that are listed here. So the top left picture is what's called a chevron osteotomy, and you'll see that they basically just they didn't do anything really with the phalange, but with that first metatarsal, they kind of broke the first metatarsal, repositioned it, and then just put one screw in the first metatarsal. So that's one option. The second one, the bottom middle one, is called the McBride procedure, where they are, again, they're basically doing like an osteotomy. So they're breaking that first metatarsal. They're actually cutting in two different places, and then repositioning, and then using some sort of hardware fixation screws. And then there's the triple distal osteotomy, which you'll see at the top right, and that's where they actually cut 3 areas. So they're cutting the metatarsal, but they're also cutting in the phalange, and then using hardware of both the metatarsal and the phalange. So that would probably be for the more significant problem. Precautions are completely based on the procedure, so really important to talk to the surgeon. Most patients are going to be non-weight bearing for 4 to 6 weeks, and they're going to be really uncomfortable. I have to be honest with you guys. Again, this is not a fun surgery. If you don't have to do it, don't do it. So preoperatively, we're talking to them about the fact that they're going to have pain. They're going to be uncomfortable for a couple weeks and maybe longer, but usually a couple weeks. We're going to show them how to use a brace. Hopefully they're in some sort of brace, but they could be in a cast. If they're going to be using a brace, you can show them how to use it immediately before or after, and then teaching them non-weight bearing. Also helping them find the kind of shoes that they ultimately will need. If they're wearing a boot, which they're probably wearing a boot, then they don't really need to wear shoes on that involved side, so it's not as important. Okay, first phase is usually that non-weight bearing phase. So that's going to be 4 weeks, maybe 6 weeks. And our primary goal is to help kind of manage the pain and the swelling. And we're hoping that surgeons are picking the right patient population to do the surgery. Because again, it's kind of an elective surgery. It's not that necessary. And so we're hoping it's younger people that they're doing the surgery on. And if that's true, then they should be able to do a lot of movement in non-weight bearing. So they should be able to use crutches. They should be able to, either use, these are loft strand crutches. There's, the traditional crutches. In the US, they might use a scooter. So they put their foot up on like this little scooter where they push it around with their other foot to stay non-weight bearing. And so I've never seen those in China, but that's popular in the US these days. So we're educating them on that non-weight bearing status and teaching them how to stay non-weight bearing, ice elevation, those kinds of things. And our treatment is really focused on lots of exercise. So anything you can do for the uninvolved side, the uninvolved leg, and then lots of just non-weight bearing exercise for the involved side. So you'll see a picture here of the straight leg raise, clamshells, long arc quads, like knee extension, that kind of stuff. So working the knee, because again, they're probably going to be in some sort of brace or cast, and so you're really just working the hip and the knee. So the doctor's going to tell them when they can start weight bearing. 4 to 6 weeks, pretty normal. Hopefully they're getting rid of a cast. If there was a cast, hopefully that's going away at 4 weeks, so you can start doing more. And our second phase is going from, basically it's going from month 2 through month 3. And it's during this phase that we really, really want to get them to full weight bearing without pain, okay? They may not have perfect gait, or we'll practice gait, but we really want them to be able to weight bear fully without pain. We also want to think about range of motion. And so the first toe extension, the goal is that they get more than 60 degrees by the end of 3 months, okay? That is, again, this is a pain issue most of the time. So you're really kind of watching this depending on pain. Also, we want to make sure that their ankle dorsiflexion is good. So remember, some of these patients before surgery were probably lacking dorsiflexion. So you need to be measuring dorsiflexion, probably even during the first phase. If they're wearing a boot, you can measure dorsiflexion. But definitely the second phase, as we're starting to weight bear, you need to really be focusing on, if they're lacking dorsiflexion, getting their dorsiflexion to be really good. And we're going from partial weight bearing to full weight bearing. The suggestion here is that you're increasing by 25% per week, which I think is fair, because that's going to get them weight bearing then by, within about 3 weeks. So that's good. And then really talking to them about shoes, because again, they're out of the boot at this point. They should be wearing shoes. We want to make sure the shoes, if they're closed-toed shoes, that they're very wide and giving them some space to heal. So it's this period that we can start doing passive range of motion of the first toe, gentle stretching of the first toe, and then we'll start moving towards active exercises a little bit later. So we can start doing a little bit of active stuff during this phase, but it's not going to be like significantly resisted stuff at this point. Gait training. So we want to make sure that they are keeping the foot down and doing some sort of push-off, because they are going to be scared to do a push-off during terminal stance. And they really need to, at terminal stance, be able to use that big toe. So it's going to be a slow process. Again, think that they're not full weight bearing at 4 weeks or 5 weeks. They're probably going to be 7 weeks or 8 weeks that they're going to be full weight bearing. So during that time, you're teaching them how to push off. And then when they can be full weight bearing, then they should be able to do it with less fear, but there could still be pain. I'll be honest with you guys, the pain can last for a couple months. Hopefully not. Hopefully the surgery goes well and you don't have that situation, but it is common. Our other treatment is strengthening at the ankle. So again, we're not going to push the big toe so much, but we're going to strengthen at the ankle. You can do foot intrinsic exercises. These are going to be, not really weight bearing, but we're sitting and doing things like scrunching a towel and picking up marbles and all those kinds of things. And then you can do basic weight bearing activities like proprioception and balance training. So you can get them to single leg stance, again, by about 8 weeks. That's fine. And so you're just starting to do more proprioception type activities. So we really want, by the end of 3 months, to get them to a normal gait pattern. We also want that full range of motion into extension, so 60 degrees or more, and full ankle dorsiflexion. So after 12 weeks, this is our primary goal is to go back to whatever they were doing functionally before. So that's not necessarily sport, but if they had to walk to the grocery store and have to do a bunch of stairs to bring their groceries inside, they should be able to do that during the third phase. And during this phase, you're doing more stretching. You're keeping up with the stretching. You might get a little bit more aggressive with stretching. You can teach them how to do self-mobilization, which is not written here, but that's another thing that can be helpful for these guys, is to mobilize it themselves. And then you're just doing more progressive loading. So this is a group, again, if they're younger and they're used to being relatively athletic, you might not have to see them at this last phase, like, after 3 months or so. But if they're a little bit awkward and, they don't have great coordination, you might want to see them a couple times during phase 3 to progress things. So like step downs, like going down the stairs, because that's a lot of dorsiflexion and it's a lot of toe control. Lunges, single leg heel raises, which are going to be really challenging for these guys, right? Those are the kinds of things we're doing after 3 months. And then progressing proprioception activities. But the biggest thing is to make sure that they know the shoes to wear and changing their lifestyle so that they don't end up leading to this problem again. So you're looking at their mechanics, you're really trying to fix their mechanics and helping them understand that they can't wear those shoes anymore because it's just going to cause irritability and possibly lead them to a problem in the future.